since you started using ultrasound so early in your career, even when you were third years, you probably saw some incidents where ultrasound could easily have been applied and maybe wasn't, or wasn't being used correctly by your senior faculty, residents, even senior medical students. How did you handle those kind of situations?
You know, by the time I actually got comfortable using ultrasound here with some of our models, or just using it on one another to learn, it was kind of early on in my third year when I saw maybe some things that could have used a correction or two while I was on the ward. Specifically, one story I remember when I was on the neuro ICU, I had a senior resident who was trying to put in a peripheral line with the ultrasound machine. I was really struggling not only to identify what vessels were what, and spent over about a half hour trying to put this arterial line in this gentleman who was in quite a bit of pain at that point. But I don't think I had built up the confidence and comfort with ultrasound to kind of step in and say, hey, there's a few extra things you could probably do to help ease your procedure here. So that's just kind of one of the first times I realized that ultrasound was being used all the time in the hospital for a lot of different things, but sometimes was not being used as effectively as it could be.
I really haven't seen too much of ultrasound being misused. I've seen it being underused, especially in my current rotation, which is at an outside hospital. They don't have an ultrasound machine in their medical ICU. And just today we rounded on 3 patients with congestive heart failure who were hypotensive. And the question was raised whether we give fluids or not.
And you
I
had an
gently
answer.
suggested that we do the IVC ultrasound.
Yeah.
But that would have entailed me going all the way down to the trauma bay, taking their ultrasound, the ED not having an ultrasound for a little while, and then having my attending come in and having us both scan so that we could actually use those scans. And we ended up just putting in central venous access and getting a CVP instead.
And did that help?
It eventually helped, but it could have been done more quickly.
Yeah. Okay. Have you ever found, now after you're now into your 4th year, where you have the skill that those around you maybe don't have, in situations like what you just described, where you want it to be used but maybe people aren't comfortable with it, even if it's available to you and it's sitting right there and you just want to turn it on, and that's like the biggest hurdle to get over for the rest of the team, is that turning the power, where the power button is, and using the machine?
Pretty much all the time now. I just got off of my emergency medicine rotation, and every day, like, the first thing I did after I met my attending was like try to locate where the ultrasound machine was. It's because I knew there was plenty of opportunity to do scans and things like that, and maybe some of the interns or even senior residents who were a little busy running around and attending to patients maybe didn't have the time to go in and actually do scans themselves. But I remember I was at my OBGYN rotation, actually at an outside hospital here, with one of the interns, and we had a mom come in who was late in her pregnancy and was just concerned. She didn't feel the baby moving, so we were just going to do an amniotic fluid index, and so we dragged the ultrasound machine into the room, and I thought, oh great, you know, this is one of the first times, this is before my EM rotation or anything, that I actually get to use ultrasound in the clinic setting. How cool, and I'm pretty comfortable now with it or whatever. And she went in and was kind of moving the probes. I had never done an AFI before, but I knew the basics of what we were looking at for that kind of deep pocket, the same thing we do for ascites measurement or things like that. And she was kind of moving the probe all around the patient's belly and all 3 planes at the same time. And you know, I was kind of cringing in the back of my head, saying, "Oh, there's a really systematic way to do this." And
your ultrasound instructor would be
she
so mad.
She just didn't know. And so I said, you know, she actually told me verbatim. She goes, "I don't know really how to describe the movements to you, but you just kind of move around so you find that deep pocket." I thought, oh, what a great, you know, time to stop and be like, oh, well, I can, you know, maybe if you want to learn, I can teach you some of these movements. They all actually have names, and if you do it in a nice systematic way, you sweep and slide and then kind of rotate and find your pockets. And just that was information that was not available to her in her training, but that I had, and so I was able to kind of, after we were done with that patient, sit down and spend 5 minutes teaching. So it was kind of nice.
How was that received?
Pretty good. I think we're in a field where learning is a ever-present part of our career. So I think people are very receptive to being, oh, you have a skill that I don't have. Let me take this as an opportunity to learn. Yes, you may be junior in rank, but you have some valuable information that could kind of help with clinical decision making or anything here on the board. So that's pretty well received, as long as you don't act like, oh, I know everything about ultrasound and you don't know anything. And they're like, yeah, well, I'm a resident, I do this every day, I know a little bit. So just got to find that right tact.
Yeah, I think being humble about everything is really the way to go.